Welcome to Discussions with Dr. G, where nursing truths get spilled hotter than a fresh urine culture. I'm Dr. G, your sarcastic guide through the microbial mayhem. Today, we're flushing out the facts on UTI medications. Strap in and stay hydrated. Let's kick things off with the OGs of UTI treatment, sulfonamides and trimethoprim. You probably know this as Bactrim. Or if you're feeling fancy, sulfamethoxazole trimethoprim, SMXTMP. These are the go-tos for your run-of-the-mill, uncomplicated UTI. But, and this is a big but, they're also used for things like otitis media, bronchitis, shigellosis, and sometimes even MRSA skin infections. So they're kind of a utility player in the antibiotic lineup. Now, let's talk about the fun stuff. Side effects. Crystalluria is one. Think of them as tiny kidney daggers. Not exactly the visual you want, but it does get the point across. This is why you have to push fluids 2 to 3 liters a day minimum. Otherwise, you're literally just asking for trouble. Then there's hypersensitivity reactions, which can range from a simple rash to full-blown SJS, or Stevens-Johnson syndrome. If you see a rash, stop the drug. Don't try to be a hero. Cardinal signs and symptoms of SJS are, here's your acronym, fever, burn. F for fever, right? E, erythematous rash. This is macules that may blister on the skin. V, very painful skin. It's tender and it almost has like a burning sensation for the patient. E, epidermal detachment. This is a positive Nikolsky sign. Literally, the skin starts to slough off. R, ruptured bullae. That is skin and mucosal blistering. B, blisters. Like I said, especially in the mucous membranes. U, ulceration. Oral, ocular, genital ulcerations. R for red eyes. They may have conjunctivitis or some kind of ocular involvement. And then the N is that Nikolsky sign. It's positive. The skin is sloughing off with gentle pressure. So again, fever, burn, your signs and symptoms for SJS. And let's not forget blood dyscrasias, anemia, leukopenia, all that jazz. So you're monitoring CBCs. Oh, and don't forget kernicterus, which is a rare but serious type of brain damage that can occur in newborns due to severe untreated jaundice. It happens when high levels of bilirubin, which is a yellow pigment, build up in their blood and spread to the brain tissue. This can lead to permanent neurological damage. Kernicterus. Hyperkalemia is another one, especially if your patient is elderly or already on ACE inhibitors. I mean, it's like this med is collecting side effects like Pokemon. Quick story. One time, a student came to me convinced that Bactrim was the reason her patient had this glowing tan. Turns out she'd mixed up photosensitivity with, a spray tan mishap. Photosensitivity means a sunburn, not a golden glow. So teach your patients to use sun protection or they'll be lobster red and blaming you for it. And of course, allergies. You have to check for allergies. Allergies to sulfa drugs specifically. And be careful with any kind of renal impairment. Where was I going with this? Oh, right. Hydrate, monitor, teach. That's going to be your mantra for these meds. Moving on, let's talk about nitrofurantoin, also known as macrobid, if you're on a first name basis, that is. This one's strictly for lower UTIs like cystitis. Don't even think about using it for pyelonephritis or anything fancy. The big thing with nitrofurantoin is GI upset, so always tell your patients to take it with food. And here's the kicker, brown urine. Yeah, it's going to look like they dumped a cup of cold brew in the toilet. It's totally harmless, but if you don't warn your patient, you're going to get a panic call at 2 a.m. asking if they're dying. It happens. All right, peripheral neuropathy, especially if someone's on this for long term or if they have renal impairment. So if your patient starts complaining about numbness or tingling, that is your cue to reassess. Pulmonary reactions are rare, but serious. Think cough, chest pain, fever, and of course, avoid this one in patients with bad kidneys. The drug just won't concentrate in the urine, so you're basically giving them side effects for free. Now, let's get into those heavy hitters, our fluoroquinolones. Ciprofloxacin, levofloxacin, all those floxacins. These are for complicated UTIs like pyelonephritis, or when you're dealing with prostatitis, or even some gnarly GI infections. But they come with tendon risks. I'm talking tendon rupture, especially Achilles tendon. If your patient says their ankle hurts, stop the drugs. Don't wait for them to snap something. Fluoroquinolones also bring photosensitivity. So again, sunburn city. GI upset, CNS effects like dizziness or confusion, especially in the elderly, and QT prolongation. And of course, it's an antibiotic, so why wouldn't there be a risk for C. diff? Oh, and if your patient is under 18 or pregnant, it's a definite no for fluoroquinolones. Cartilage damage is not a souvenir anybody wants. Also, dairy and antacids mess with absorption, so space these out. And if the patient's on warfarin, watch them for increased bleeding risk. It's like these drugs come with a user manual longer than my last IKEA bookshelf. Bottom line, warn about brown or orange urine, teach about tendon pain, and keep an eye on those elderly patients for CNS changes. And please save yourself the midnight phone calls by preparing your patients for all of the weird things their pee might do. All right, let's wrap up with phenazopyridine, also known as pyridium. This is the MVP of symptom relief. No, it is not an antibiotic. Do not let anyone tell you it is, because it is not. It's just there to make peeing suck less. It relieves the pain, the burning, and the urgency, but it does not cure the infection because it's not an antibiotic. And yes, that is a hill that I am willing to die on. The most memorable thing about pyridium, the neon orange urine. It's like they're dropping an orange highlighter in the toilet instead of pee. So always warn your patient about the color change and that it can even mess with urine tests. Key tip, limit use to 2 days, especially if you're on antibiotics. And don't use it as a replacement for actual treatment. Avoid renal or hepatic impairment because the drug can build up and cause more harm than good. And seriously warn about the staining. No one wants to explain orange underwear to their roommate. So that's the rundown on UTI meds. Hydrate with sulfonamides, prep for brown pee with nitrofurantoin, watch those tendons with fluoroquinolones, and don't let pyridium's orange magic fool you into thinking the infection is gone. Thanks for tuning in to Discussions with Dr. G, where we've just peed all over the topics of UTIs, in the most sterile way, of course. I'm Dr. G, signing off until next time, when who knows which meds will take a hot seat. Stay sarcastic, stay scholarly, and remember, always wipe front to back.